Look at this. What else is there? Look at that, so much glucose is there. We don't want to forget that. Okay, remember all this glucose were here in the plasma, you know, from this gluconeogenesis, glycogenolysis, okay, lipolysis, you know, from all of that, you know, there's lots of glucose is accumulating, okay? So that is called hyperglycemia, okay? And whenever there's lots of glucose is present in here, what is going to happen? The filtered, look at the kidney here. The filtered load of glucose increases, right? Significantly, okay? So whenever there's a filtered load of glucose goes like, let's say, greater than like 250 milliequivalent per liter, then that is a problem here now. What is the problem is that? Look, what is going to happen is that you guys remember from the kidney that the proximal tubules has what? The glucose transporter, right? The glucose transporter, so sodium glucose transporter, right? They have this transfer. But these glucose transporters, okay, they have this phenomenon known as transport maximum, okay? They can only transport certain amount of glucose, okay? Because if there's too much high level of glucose, this is freely filtering out, and then what happens is this glucose transport down here, they get saturated, okay? And when they get saturated, they can no longer reabsorb the glucose. Okay, some of the sodium does not get reabsorbed too. So what is going to happen? The glucose is going to go to the urine. So what do you get? You get a glucose urea. Okay, you get glucose urea. That's what is going to happen, okay, in urine. Not only that, look, in the glucose, with the glucose, okay, because there's a lot of glucose. And when there's a lot of glucose, okay, what is going to happen is that, you know, glucose loves water. Let's go with that, okay? So whenever glucose is there, from, let's say, like from muscles, like from like brain, like, okay, what is happening is that, you know, glucose will extract water. So water will sort of like shift from your tissues, okay, peripheral tissues, okay, from your brain, let's say from your muscles, the water will come, okay? And water will come, okay, because it will follow the glucose, okay? So what is going to happen when that happens? Okay, because that's going to shrink, right? Because all these guys are going to, like those cells are going to shrink. And the glucose, because it's a high level of glucose is there, okay, what is going to happen is that, you know, that's going to disturb your, you know, osmolarity, okay? Well, how are they going to disturb osmolarity? Let's write down here. How do you find osmolarity here? Let's write the equation down here, okay? Okay, let me write down the equation right here, guys, okay? So usually the way you find the osmolarity is, okay, they do osmolarity, okay, the normal person is, you do your 2 times, you add the sodium, okay, and you add your blood urea nitrogen divided by 2.8, and then plus your glucose level, okay, your glucose, plasma glucose level divided by 18, okay, that's what you usually do, okay, this is usually you find the osmolarity, okay, whenever this glucose, now in our case, this glucose is going really up, right? So if the glucose go really up, it becomes like the 350 milliosmoles per liters. Okay, let's say this sodium is what? Let's say we'll say for our case 140, right? Plus your this blood urea nitrogen also goes up. Let's just talk about how that goes up. Remember, the reason why it goes up is because you're making what? You're triggering gluconeogenesis process, right? And then from that process, what do you make amine group 2, right? Ammonia and all, right? Because from the amino acids, you make the ammonia, right? And those ammonia, by breaking down, what is that? So those ammonia gets converted into urea. So there's an increased level of ureagenesis is there, okay? That's why, you know, the blood urea nitrogen level also goes up, okay? That's why. So now, let's say this goes up, and usually it's like, you know, different books made different cells, but it's like about like a 20 milliequivalent liters, but that is usually like, you know, less than that usually that's normal, okay, per burn. But in our case, let's say this is like went up to like 30, okay, and we'll just divide it by 2.8, and glucose went down to, we'll simply say this went up to 350 milliequivalent per liters. So when you do this math, okay, so when you do this, okay, you should have, okay, more than like, let's say, like 320 milliosmoles per liters. And normally, your osmolarity is what? About like 200 and, let's say about your 287 or so. That is usually the normal level of osmolarity. But if you do this math, okay, basically this osmolarity is, I mean, I'm not doing the math, but if you do it, okay, what is going to happen is that you're going to see hyperosmolar, okay? So that means there is a osmolarity has been disturbed, okay? So when the osmolarity is disturbed, when there's a hyperosmolar, what is going to happen is a lot of glucose is coming down. At the same time, this water, glucose is tracking water. So what is going to happen is that the water will also go to the urine. So what is going to cause that? That's going to cause polyuria, right? Polyuria, the frequent urination will happen. That is also clinical manifestations of your DKA, right? That. On top of that, okay, look, this lot of, what is going to happen is this. On top of that, like there's a lot of potassium is also in plasma is accumulating, right? This potassium is also get filtered out. It does not get used because there's a lot of, and then because remember, water is kind of bring it with it too. So you're going to have this potassium urea, yeah, that's potassium in the urine too. That's what you're going to see, okay? That's why. Not only this, look at what is accumulating here, a lot of this ketone bodies. This ketone body, you see a ketouria too, okay? Because ketouria also going to go down, okay? Now, not only that, you're going to see this here, okay? Not only this, look, what is happening in hypercalcemia was there. Calcium is going to, so your calciuria is also there, okay? You're going to throw calciuria too, okay? Now, what is going to happen, other thing, is that not only this is going to happen, guys, you have to think about phosphate. What is going to happen to phosphate? Okay, remember, you know, this intercalated cells also like what secrete out potassium, right? They also secrete out from the intercalated cells. But also if there's too much proton, right? There is too much proton, the kidney also throws out protons, okay? Because this diabetic ketoacidosis is leading into what? It's a metabolic acidosis, right? So because there's a metabolic acidosis, there's a lot of acid production there. The kidney tries to, you know, by producing bicarb and also excretes out, okay, this proton, right? And when this excretes out these protons, okay, protons are dangerous, okay? So what is going to happen is a proton, what is going to get proton is going to attach with you, okay? There will be a shift of there will be a shift of your phosphate from your cell to your extracellular fluid, okay? So whenever there is that, what is going to happen is that, okay, a lot of this phosphate will come to your plasma, okay? But this phosphate will later, what happens is that they will get, you know, filtered and they will bound with this proton and become your tritable acid. Okay, that's tritable acid, okay? Because remember, it's a monophasic for HPO4 with the 2 minuses, and later it will become H2PO4 with 1 minus. That's what it means. Now, this is called your tritable acid, right? And you see that increased level of tritable acid, okay? And because of this whole water is also flowing so fast, you know, this along with that, the phosphate is going to also go to the urine. So end result is that you see the decreased level of phosphate in your plasma. So what is that called? We call this hypophosphatemia. Okay, so write it down. Should I write it down? Okay, there's a hypophosphatemia. You need to see that in DKA too. Okay, now whenever there's a lot of this, okay, there's a glucoseuria, polyuria, frequent urinations, right? You're losing potassium also. There's a lot of ketone bodies, you're losing that, okay? You're losing calcium. You're also losing phosphate, so that is causing what is hypophosphatemia, okay? Now, not only this is happening here, what else is going to happen here? Whenever you lose like a lot of polyuria, okay, that means you're losing a lot of water, right? And also the lot of water is the glucose is actually a lot of water, and these cells are like shrinking. That because remember, our brain requires a lot of water, right? And when you are if you are removing a lot of water, okay, and also you're passing out, these frequent urinations, that means what? That means there's a loss of fluid, right? There's a loss of fluid, loss of fluid, guys. So whenever there's a loss of fluid, what is going to happen? That could lead into hypovolemic shock, okay? That's what it is. And whenever there's a loss of fluid, what is going to happen? Osmolarity goes up even. And when the osmolarity goes up, what is going to happen is that if you come back here in the hypothalamus, guys, remember? There's a blood-brain barriers are disturbed, right? this area in the hypothalamus, the blood-brain barrier disturbs, and they're going to trigger, okay, they're going to trigger the thrust center, okay, so that way you can increase the intake of water. Because this hyperosmolarity is leading into what? Polydipsia, right? That's what is reducing into it. Polydipsia is there, okay, and then not only this, because of this, the loss of fluid, you become severely dehydrated, right? So dehydrations, right? Dehydrations, and then because of that, what happens? You see a dry mouth, and you see a decrease in skin turgor. You see, these are all the clinical manifestations that you could see in DKA, okay? And whenever there's a lot of hyperosmolarity, it goes to this, okay, in your brain, and it can actually, you know, in your cerebral cortex, okay, and it can, you know, it can play with that, you know, and it could, you know, disturb your mental status, okay? It could do that, okay? Not only that, you know, this lot of these ketone bodies, okay? There's a ketone bodies, you know, if you guys remember, like around like a fourth ventricle, okay, let's just make this, around this fourth ventricle, like let's write down here, there is a something called, you know, around that, okay, something called your chemoreceptor trigger zone, okay, that is what it is. Is that chemoreceptor trigger zone, CRTZ, okay? This chemoreceptor trigger zone, which is located within the area of postrema, okay? And then what happens is these ketone bodies, okay, you know what they could do? They could trigger this chemoreceptor triggering zones, and this chemoreceptor triggering zone, which is located in the area of postrema, that is communication with your vomiting center. Okay, so what is going to happen around this side? Let's say this is a vomiting center. It's going to trigger this, so the patient will have what? You know, patient might get nausea, okay, even vomiting. Okay, that's what's going to happen there, right? Now, that's what's going to happen. What about in the GI system here, okay? Look, there's a lot of acid production there, a lot of protein is there. Okay, a lot of these acid productions, okay, and a lot of this, even this high level of potassiums, you know, they can irritate this GI, okay? They can irritate GI, and then you can have abdominal pain, okay? Abdominal pain and discomfort you can get, okay? Because ultimately what it's going to do is they're going to decrease the GI motility. That's what it's going to do, okay? They're going to decrease your GI motility, okay? That's what it's going to do. And you're going to have abdominal discomfort and abdominal pain. That you could see that, okay? That is what is going to happen. What is happening in the level of when it comes about, let's say, heart? We haven't talked about the heart. Guys, remember initially what was triggered? Epinephrine, right? Epinephrine has a receptor. Even glucagon has a receptor there, okay, in the heart. Epinephrine has a receptor in here with the beta receptors on acidotic cells. And what is going to happen here? Okay, you are going to increase what? Heart rate, right? That's what is going to happen, because remember, with the acidotic cells, okay, there's a specialized type of cells here, okay, those acidotic cells. When glucagon epinephrine would bind into the receptors, what is going to happen is that, you know, ultimately the result is that it's going to, you know, it's going to activate this, you know, GS pathway and protein kinase A, and they are going to increase these activated acidotic cells, okay, by forming more cross-cycle bridges and more calcium going there, right? I mean, more calcium releasing from the intracellular. So ultimately the result is what? You have an increase in heart rate. So what is going to happen is the patient might have a tachycardia, okay? Because remember, you write down here, your cardiac output is equal to what? Stroke volume times heart rate. That's what it is. And not only that, whenever there is a look, we lost loss of fluid, right? Whenever there's a loss of fluid, what is going to happen? So what is going to get triggered? Loss of fluid, okay? When the loss of fluid is there, okay, this pathway is going to get triggered. Look, when the loss of fluid is there, okay, the nucleus tractors, okay, are going to get they're going to give signals, and then they're going to stimulate the cardioaxillary centers, okay? That's what it's going to do. Because what are you going to have when you have loss of fluid, and then your peripheral tissue needs supply of nutrients, right? So we want to increase the cardiac output, Okay, so that is going to give a stimulation to the cardiac accelerator centers, even the vasomotor center nuclei. That's what is going to happen here, right? Now, when they, and that is going to even more enhances the activity of this, okay, because there's a decrease of blood volume, and then there will be more increase in heart rate. That is going to be tachycardia, and then they will try to increase the contractibility in that pathway too, okay, by increasing the cardiac output. But remember, in spite of their keeping increasing the cardiac output, okay, they still not able to, they'll try to, because of the path, they'll try to increase the cardiac output. But what's one more thing? When you release the cardiac output, remember what is producing a lot of here? Okay, what is? Cardiac output going up. Look, a lot of this blood vessel artery, there's a lot of like lactate was there, right? A lot of lactate. Okay, remember autoregulations, proton concentration, a lot of carbon dioxide is there, okay? A lot of that. So whenever a lot of these guys is there, what is going to happen? They'll do vasodilations of blood vessels. The total peripheral resistance goes down, okay? So end result is there's a loss of blood volume, and what is going to happen is that because of this, there's a lot of lactate, a lot of proton, a lot of carbon dioxide, they'll do vasodilations, okay? So in the patient, the DKA, because of this, the patient will have what? Hypotension. So what are they going to have? Hypotension, low blood pressure. That's what they will see. They'll have. Okay, that's really important that you know that. Okay. Now after this, okay, because these ketone bodies are what? They're acidosis, right? So let me just quickly talk about the concept of anion gap. What does anion gap mean? Let's just talk about that too, okay? We're going to talk about that. And we can talk about this one in anion gap, right? Let's write down here. Okay, basically anion gap, okay, how do we do? Because remember, anion gaps is basically means that the balance of your negatively and positively electrolytes. That's it, right? So basically, let's just say, okay, what is this? You can say usually what is the level of electrolytes? Let's say this is my sodium, okay? And then we can say this is my potassium, right? And then you can say this is my mesonions, which is a chloride, and other one is what? Other one is your bicarb, right? And there's other one too, okay, like phosphate and all that too. But anyways, usually there's a balance of this too. So usually what is the level of your sodium, in plasma? We say 140 equivalent per liter, right? 40 milliequivalent per liters. That's what it is, right? And potassium is, let's say, you can say like 3 or 4 or 5, whatever you want to say. Let's say you can say 5 milliequivalent per liter. And calcium and chloride is what? Chloride is usually about, let's say 105, right? 105. And then your bicarb is like about from 20 to 25. So in our case, we'll just say like 20 to 28, also we'll say 28, right? So whenever this is 145, okay, and then you just subtract this too. Because this is anion, this is a, cations, right? So 140 plus 5 is 145 minus, okay, 105 is 130. This is what? 15 milliequivalent per liter. That's what it is. Okay, so this is a normal anion gap. Any number that comes within, let's say, between 12 to 16 milliequivalent per liter, different books might say different things. Then this is considered to be normal anion gap, okay? Which basically means is that, because there's a potassium level is attached there, okay? So, sometimes we can even ignore the potassium level and we can simply just do the, with the sodium too. If we just do the sodium, okay, you will probably get about what, 10 milliequivalent per liters, right? And if you just do the sodium without a potassium, then usually from 8 to 12 milliequivalent per liter, that would be considered as a normal anion gap, okay? Here, okay, about this is a normal, but here, what is happening here is that the bicarb is going down, okay? So bicarb is, like, let's say this is bicarb, but here the bicarb is going down. So when the bicarb goes down, look, let's say, it goes down here, on 7, and then on top of this, what is there is the ketone bodies. A lot of ketone bodies are there, okay? That is what is replacing the bicarb with, right? So in that case, look, if we do this, okay, we'll just say 145, okay? And also, like, look, this level also goes up, right? Potassium level also goes up because of the hyperkalemia, okay? But let's just say for our case, okay, we'll just do the sodium, okay, it's 140, and then minus our chloride is like, let's say about the same, 105, but this bicap went down to, let's say 15, okay? That's just 15. So you do 105, okay, that's the level, plus the 15. What is that going to give you? 120, right? So 140 minus, look, from here, 140 minus 120. What is this? 20 milliequivalent per liter, okay? That says that this 20 this is above the normal, right? So this means there's increase in anion gap, okay? And that tells you about the metabolic acidosis, okay? So in the DKA, okay, you will have an increase in anion gap, okay? Increase in anion gap. I'm writing it everywhere, but just know this, okay? Now, quickly, okay, let me also quickly talk about this one. Here, guys, you know, we did the osmolarity. So let's just quickly find the osmolarity of this one, okay? So whenever you multiply 2 times 140, what is that? It's a 280 right here, okay? 280, and then plus you do 30 divided by 2.8, that gives you like about 10.7, plus let's say 350 divided by 18, that gives you 19 point something. So whenever you add 280 plus let's say 19.44 plus 10, that's about like a 309.44, okay? It tells you. So if it's, okay, if it's usually, okay, but usually this number is going to be relatively like bigger than this, but usually if your osmolarity is usually about like let's say 287 milliequivalent per liter, this means this osmolarity increased, okay? And this is how mathematically you can actually figure out, okay? Mathematically you can figure out the osmolarity, okay?